Welcome back to the What's in Your Head podcast, Tools for Pain and Dizziness. I'm Pete Schultz, Doctor of Physical Therapy. Before we begin, I'd like to remind you that this podcast is for educational purposes only and should not replace medical advice from your physician or healthcare provider. Every person is different, and if you're experiencing episodes of severe dizziness, hearing loss, or other concerning symptoms, it's important to be evaluated by a qualified healthcare professional. In today's episode, it's all about Ménière's disease, a condition that can be confusing, unpredictable, and frightening for the people who are experiencing it. If you've ever had a sudden spinning episode that seemed to come out of nowhere, along with ringing in one ear, pressure in an ear, or fluctuating hearing loss, you've probably wondered what is happening and whether it will ever get better. We'll discuss what Ménière's disease is, how it's diagnosed, current medical treatments, the role of vestibular rehabilitation, and how techniques like exercise, stress management, mindfulness, and biofeedback can help regain confidence and improve your quality of life. Ménière's disease is a disorder of the inner ear characterized by recurring episodes of vertigo, which is a spinning sensation, fluctuating hearing loss, which means the hearing loss comes and goes, ringing in the ear or tinnitus, a feeling of fullness or pressure in the ear. The exact cause isn't completely understood, but it's believed to involve an abnormal buildup of fluid in the inner ear called endolymphatic hydrops. It affects 1 out of 5,000 people. It affects male and females equally. So there's about a 50-50 ratio to male to female. In order to be diagnosed as Ménière's disease, you have to have 2 or more spontaneous vertigo episodes lasting up to 24 hours. Hearing loss in one ear associated with vertigo, and mid to low frequency hearing loss. So you can still hear high frequency sounds like a bird tweeting, but you lose that low to mid frequency hearing loss. You'll also have tinnitus and fluctuating ear symptoms. The diagnosis of Ménière's disease is very specific, and it doesn't fit into the mold of other vestibular diagnoses. Let's talk about some of these symptoms individually. Vertigo is a sensation of spinning. Your vertigo will be sudden onset. It usually lasts 20 minutes to several hours and can include nausea and vomiting, and often leaves people exhausted afterwards. Hearing loss usually affects only one ear initially, and it may fluctuate early on, and it will become permanent over time. So depending on how many symptoms you have. The tinnitus may be described as ringing in the ears or roaring in the ears or buzzing in the ears or humming. And the sensation of ear fullness will feel like pressure, congestion, almost like feeling like your ear wants to pop and can't pop. Now, one of the important things about Ménière's disease is there's no typical Ménière's patient. Everyone presents a little bit differently. Some people have attacks every week. Some people go years without symptoms and go years from one attack to the other. Some people have severe hearing loss. Some people have minimal hearing loss. Some people really struggle with the vestibular side of it and have a lot of dizziness and nausea, and others don't have as much dizziness and nausea. Some people have severe balance deficits, and others have minimal balance deficits. And there's also different stages of the disease. In the early disease, when you've only had like 1 or 2 attacks, and again, we don't know when these occur, the symptoms may be more mild. Or you may have severe symptoms initially, and then over time, the symptoms aren't as bad. But when people have recurring attacks, some of the symptoms do become permanent. Now, other people might have one symptom and then go into remission and never have another symptom again and have no permanent damage. What we have to understand here is Ménière's disease unfortunately, is unpredictable. And we really don't have a great understanding of when you're going to have an attack or not. But that being said, there is a lot of things you could do for it, and you could strengthen yourself. You could improve your balance. You could improve your autonomic nervous system function. And there are things to do and there are solutions. Now, because of this unpredictability, there's a huge emotional impact and there's a lot of anxiety associated with Meniere's disease. People are going to wonder, when will I have another attack? What if I have another attack? What if I have an attack when I'm on vacation or other things? There's a lot of worry involved, and there is things we could do for the anxiety. Now, when the anxiety gets really bad, it could become disabling. This uncertainty an anxiety becomes almost as bad as the Meniere's symptoms, as the vestibular symptoms. When we look at them as physical therapists, we want to control the things we can control. Oh, we're going to work on the nervous system. We're going to work on your balance. I'm going to give you some vestibular exercises. And there are things that you could do for Meniere's. Next, I want to get into how Meniere's disease is diagnosed. Well, the first thing we're going to do is a subjective history. So I'm going to ask a lot of questions. And some of these questions might be, how long do the attacks last? How often do these attacks happen? Are you having any hearing changes? Is there any ringing in the ears? Is it in one ear or both ears? Do you have a history of migraine or vestibular migraine? And are you having any neurologic symptoms? Then usually the ear doctor or an ear, nose, and throat doctor will perform a hearing test or audiogram. Now, one of the hallmark findings of Meniere's disease is that you have fluctuating low frequency, really low to mid frequency hearing loss. So that means the fluctuation means that these hearing loss symptoms may be present during an attack, and then they come back to normal after, or they might come back a little less than normal. Well, we don't understand, but one of the key factors in the audiogram and in the hearing testing is going to be this fluctuating low to mid frequency hearing loss. And usually the more attacks you have, there is a worsening of the hearing loss in Meniere's. And that's really one of the ways we could distinguish Meniere's from other types of dizziness, is the hearing loss and the ear symptoms that are usually one-sided and associated with Meniere's. Then we do vestibular testing. The ENT or a vestibular therapist might do vestibular testing, including VNG, which is video nystagmography, caloric testing. We might do some head impulse testing, VEMP testing, rotary chair testing, dynamic posturography. I'm not going to go into each one of these tests, but these are some of the testing procedures that the ENT or the vestibular therapist is going to perform to see if there's any vestibular loss going on. Now, these tests don't necessarily diagnose Meniere's, because we already talked about the diagnosis of Meniere's, what we're looking for, but they could rule out some other issues, and they could kind of tell you how your vestibular system is functioning. Sometimes the doctor may order an MRI. Now, the MRI, again, isn't used to diagnose Meniere's, but it's used to rule out some other disorders. It's used to rule out an acoustic neuroma, stroke, multiple sclerosis, or other neurologic diseases or disorders. Well, it's important to really figure out and differentiate Meniere's disease from some other type of symptoms. When we're trying to figure out if this is Meniere's disease or it's something else, we usually use a differential diagnosis. We're trying to see what other disorders it may or may not be, and kind of tease out to see if we feel the diagnosis should be Meniere's disease. Some of the things we're going to rule out will be vestibular migraine. Now, a vestibular migraine will last 5 to 72 hours of dizzy spells, possible headache, and light and sound sensitivity. A vestibular migraine acts like a regular migraine. You're going to have either a really bad headache or dizzy spells for a prolonged period of time, maybe 5 to 72 hours. And at that time, you're going to be really uncomfortable. And it's usually associated with light and sound sensitivity, and usually have a history of migraine, usually a history or at least a family history of migraine. Now, BPPV is positional vertigo. With BPPV, you'll have short bursts of vertigo followed by movements like rolling over in bed or looking up. With BPPV, you might look up quickly and the room might spin for 10 seconds, or you might roll over in bed to the right and the room will spin for 10 seconds and then stop. And then afterwards, the spinning only goes on for a short period of time, like 10 seconds, but then afterwards you feel like this low level dizziness and nausea. Another thing we're looking for would be vestibular neuritis. Now, vestibular neuritis is usually unilateral hearing loss caused by basically an innervation or a disruption in the vestibular nerve, which is one of the cranial nerves. And you'll have really severe dizziness and vertigo for usually for a few days. That's like 1 to 3 days. People are experiencing really bad dizziness and vertigo. And usually, initially, when people have vestibular neuritis, they will go to the emergency department thinking that they're having a stroke, and then it'll be identified as vestibular neuritis. With vestibular neuritis, for those first few days, you have extreme vertigo, dizziness, nausea. And then after those 3 days, you usually have a lot of imbalance. You're really off balance. You have a hard time stabilizing your visual system. When your head moves, things move with you, and it's very uncomfortable. So that would be vestibular neuritis. The next disorder would be 3PD, persistent postural perceptual dizziness. So now with 3PD, you're dizzy all the time. You're just always dizzy. It never really stops. It's this low level dizziness all the time. And people have imbalance and they feel really that their system is off. And it usually, 3PD usually follows a vestibular episode like positional vertigo or BPPV. And then over time, you slowly develop triple PD or 3PD. Another thing we're looking to rule out is superior canal dehiscence. Superior canal dehiscence is one of your semicircular canals, might have a little thinning or hole on the top of it. And when you hear loud noises, you get vertigo. You get small bouts of vertigo. That usually is the hallmark symptom of superior canal dehiscence. The other thing we're looking for is cervicogenic related dizziness. So this is dizziness due to stiffness or pain or limited range of motion in your neck. And you might get some compression of some neurovascular structures, and that might be causing some dizziness for you. I can't emphasize more the importance of when you feel dizzy, vertigo, hearing loss, get checked out by a healthcare provider. Go to an ENT. Go to an ENT who specializes in the inner ear, called a neuro-otologist. Go to a neurologist. Make sure it's okay. You want to really tease out what you have and what you're going through, because that will dictate the treatment. As we know, Ménière's disease, the mechanism is not fully understood, but there are treatment options. And some of these treatment options are really geared to improve your quality of life, right? Some of these lifestyle improvements consist of hydration, maybe a low salt diet, improving your sleep patterns, managing your stress well, maybe avoiding alcohol and large amounts of caffeine. And while these treatments are commonly recommended by the medical community, the research is a little mixed on how much each one helps, and every patient responds differently. But we're basically encouraging people. The first thing we're going to do is encourage people to live a healthier lifestyle, right? Now, there's some medications that when you go to the doctor and they figure out what is going on here and that you get diagnosed with Ménière's, there are some medications, and some of those medications help with nausea. Sometimes they'll give you diuretics or they'll give you some type of antibiotic. And these should always be discussed with your doctor, an ENT, a specialist in Ménière's before you try to take any medication on your own. Now, some advanced treatments would be steroid injections, maybe antibiotic injections, It's really rare cases. I haven't really heard of any cases of surgery, and these are the medical treatments. Now let's get into, as a physical therapist, I offer obviously non-pharmacological treatments, and that's what we specialize here in. And we're going to talk about vestibular rehabilitation and how vestibular rehabilitation works with a person who's experiencing Meniere's or a person who has Meniere's. Vestibular therapy works best in between attacks. When you're having a bad attack and you might be having vertigo or spinning for 2 days or several hours, right? You're really uncomfortable and dizzy and nauseous. Maybe if you're in the acute phase of an attack, you're not going to do much vestibular therapy. But where vestibular therapy works best is in between attacks. And like I said before, in between attacks, some people have attacks monthly. Some people will have an attack every 5 years. You don't necessarily do vestibular therapy in the acute phase of the attack, but in between attacks, vestibular therapy is very helpful. I'm going to discuss some of the different things that we will do in physical therapy to improve the symptoms and improve your lifestyle. The first thing is called gaze stabilization exercises and working on the vestibular ocular reflex. We're retraining the vestibular ocular reflex. Sometimes when you have vestibular disorders, you lose the ability to fixate on an object while your head is moving. If you focus on an object and turn your head side to side, that object typically will stay steady and still. When you following a Meniere's attack, you may see that object moving side to side while your head's moving side to side, which is very uncomfortable. There's ways to train this reflex to stabilize your vision and stabilize your gaze. The next treatment will be balance training. Balance training, we're going to progress you. You're going to balance with your feet together, with your eyes closed, while your head is turning, standing on one leg, standing on foam pads, wherever you're at in your balance, whatever's challenging for you with your particular balance, the vestibular therapist is going to challenge that in the clinic in a safe environment. What we're going to do, we're going to stand on the ground, feet together, one foot in front of the other, standing on one leg, eyes closed, while your head is turning and doing all these things to throw off your balance while you're fighting to maintain your balance. The next treatment in vestibular therapy is called habituation training. Now, habituation training, simply stated, is whatever makes you dizzy, we're going to keep doing. We're going to do more of. We have to train your vestibular system and increase the neural input, increase the nervous system, the connection between your vestibular organ and your brain to work faster and to be able to tolerate more motion. Oh, for example, if you get seasick, you want to continue to stand on a boat or simulate the rocking of a boat until you don't get sick anymore, and your body will adapt to this, and that's called habituation training. We're also going to do gait training, ambulation, and walking training. You, in the beginning, early stages, after an attack, you might need to use it. You might need to use a cane for a couple of days until you're steady. We're going to practice walking in busy environments, walking with head turns, walking in low light, negotiating obstacles. These are some of the things you would be doing in vestibular therapy. And then we're really going to be focused on fall prevention, because when you're really dizzy, especially in the older population, you're more likely to fall. And we want to really try to avoid falls. So we're going to do some fall prevention and do things around the house like picking up your throw rugs, trying to build confidence, making sure your environment is safe, making sure you're using the right assistive device if necessary. And the goal here is to improve function and make you function at the highest possible level for you. The next thing I want to discuss is, due to the unpredictability of this disease of Meniere's, and we don't know when the attack is going to come or if it is going to come, it's very anxiety provoking. It's really important to treat the nervous system and do things for your autonomic nervous system. Living with unpredictable vertigo is going to increase your anxiety, and your nervous system becomes more vigilant, and the nervous system becomes more stressed, and your sympathetic nervous system really becomes activated. People are constantly looking for more symptoms. They don't know if they're going to wake up feeling dizzy or not. And it's very anxiety provoking. It doesn't mean that you're making up these symptoms. These symptoms are totally real. They're totally structural. They're from your vestibular system. You have some lack of function or low function in your vestibular system that is going to come back, and it will work, but it's scary, and your nervous system could cause dizziness also. If someone were to have a panic attack, one of the symptoms of a panic attack is dizziness. When your sympathetic nervous system gets really activated, one of the things that happens is you get dizzy, you get lightheaded, you might get some pain, you might feel off. Sometimes these nervous system symptoms might even be worse than your vestibular symptoms. We have to treat the nervous system, and some of the ways that we treat the nervous system is by using biofeedback. So we could use biofeedback to take a look into the nervous system, measure your heart rate variability, slow down your breathing rate. We could do extended exhale breathing or a physiologic sigh. Extended exhale breathing would be, for example, breathing in for 4 seconds and then exhaling for 8 seconds. The exhale activates your parasympathetic rest and digest system. And when you have a longer exhale than inhale, that's more relaxing for your nervous system. Now, the physiologic sigh is another breathing pattern. And the physiologic sigh is where you breathe in 2 breaths through the nose and then 1 long breath in through the mouth. So it'll be like inhale, inhale, hold it for a second, and then a long exhale through your mouth. 2 inhales through the nose, 1 through the mouth. And that breathing pattern is very calming for your nervous system. Doing some kind of regular breathing. I usually recommend breathing exercises for 5-minute bursts a day. You do some extended exhale or physiologic sigh for 5 minutes. Maybe do that several times a day, especially on days that you're feeling more anxious. There's mindfulness exercises. Mindfulness exercises like somatic tracking. In somatic tracking, you're learning and you're teaching your nervous system to observe these symptoms, observe the sensation of dizziness without judging it. So you're not judging it, you're just watching it. You're watching the fluctuation and the change of sensations. You might be dizzy, you might feel fullness in your head, you might feel fullness in your ear, you might feel tightness in your neck. You're just observing these symptoms with curiosity instead of trying to avoid them. Often when we feel uncomfortable sensations, our go-to default would be to avoid them and distract yourself. But surprise, that doesn't always work. And it's often not the best strategy. With somatic tracking, you're going to observe those symptoms and you're going to breathe slowly, and then you're going to try to tell your nervous system and communicate thoughts of safety. Because ultimately, Ménière, you're going to be okay if you have Ménières. An attack of Ménières, they usually last for short periods of time, and then you're fine. Maybe over time, you might have some hearing loss and some ringing in the ears. When you're having an acute attack, that acute attack will go away and get better after a few days. The next type of treatment is neck physical therapy and posture education. Working on your neck after repeated vertigo episodes, people don't like to move their neck. People don't like to turn their head because turning your head makes you dizzy. Well, people avoid turning their head, then their neck gets stiff and they get tightness in the neck. And then when you're having an uptick in anxiety and stress from these symptoms, your shoulders might be coming up to your ears and tightening some of those upper trapezius muscles. And that neck stiffness makes you move your head less. And when you move your head less, you're getting less input to the vestibular system. And when you get less input to the vestibular system, that vestibular system weakens. And then you can't tolerate as much motion. And then with that tightness, you could also get headaches, those are uncomfortable. Neck physical therapy consists of manual physical therapy to improve range of motion and decrease some of the tone in the muscles, strengthening exercises for some of those deep cervical flexor muscles, working on your postural muscle endurance, doing things with TheraBands, or standing up against a wall and working on certain postures, certain neck postures and thoracic spine postures. Then looking at your ergonomic setup or your biomechanics, looking at how you're sitting at a desk or how you're sitting on the couch, and kind of how your sleeping positions are important. A lot of these things in neck physical therapy, we look at all these things, and because the neck can also cause dizziness, and Ménière's can cause stress and anxiety, and that anxiety could tense up your neck. And when you feel dizzy and you have a tight neck, you don't turn your head as much, and then your neck gets even stiffer. Well, what I'm trying to explain here is there's not one treatment. All these things together are going to help. We're going to making lifestyle changes, working on breathing exercise in the nervous system, working on the neck, working on the balance. All these things are going to help improve your quality of life when you have Ménière's. There is also some evidence about cardiovascular exercise. When you're out of an acute attack of Ménière's and you're not feeling as dizzy, it's important to get your cardiovascular exercise in, and that could be helpful with the overall feeling and your overall function. Some of the final takeaways here would be, although Ménière's disease could be frustrating and unpredictable, many people learn how to manage it successfully. And the goal isn't simply just treating the inner ear with medication or any type of invasive treatment. It's treating the whole person. Recovery often involves education, medical management, vestibular rehabilitation, exercise, stress reduction, improving sleep, improving confidence in walking, and family support during the process. And all these things happen gradually. So they're not going to make huge changes. You're not going to make huge changes overnight. You have to work hard, and all these things combined are going to make you feel better, less symptomatic, and more functional, improve your quality of life. Thanks for joining me on another episode of What's in Your Head? Tools for Pain and Dizziness. If you found today's episode helpful, I'd really appreciate it if you subscribe, share it with someone who might benefit, and if you can, leave a 5-star rating whenever you listen to the podcast. It really helps others find the show. If you'd like to learn more about dizziness, headaches, concussion, persistent pain, or vestibular rehabilitation, you could visit painanddizzy.com. If you want a comprehensive physical therapy evaluation, you live in New York City, you could also visit us at dynamicsportspt.com. Until next time, remember, understanding your symptoms is often the first step towards reducing fear, building confidence, and helping your nervous system move towards recovery. Thanks for listening. Have a great day.